Today, I'm going to discuss about what's new in ASA physiological classification. Now, what is the role of ASA physiological classification? It is extremely important to have a universal classification system. Why do we do a pre-op evaluation? The goal is to identify the patients with medical comorbidities, optimize them, and thus reduce the anesthetist risk and minimize the perioperative complications. And identify the patients who require further testing so that we can avoid delays and cancellations. Now, history of ASA physiological classification is more than 70 years old. First classification originated in 1941, where there were 6 categories, and ASA 5 and 6 were included for the patients undergoing emergency surgeries. It underwent further revisions in 1961 to 1963, and the ASA categories were reduced to category 5. Then it was further modified in 2014, which came up as a better classification because it had adopted examples for each ASA physical status. So it provided additional information to guide the clinicians. Also, there were improved agreement between anesthesia trained and non-anesthesia trained clinicians for hypothetical cases, and also it helped in correlation with the findings of anesthetist sitting in the pre-op room and anesthetist on the day of surgery. So they were on the same page, classifying the patients better for the surgery. So let's have a look what's new in ASA physiological classification of 2020. It has included pregnant women under category 2 irrespective of their gestational age. Even it has been realized that even in uncomplicated pregnancy with physiological changes takes place which deviates it significantly from physiology of non-pregnant patients. Also, ASA 2020 guidelines included examples for pediatric patients. And very important thing that you should remember that a full-term infant which comes to you who is less than 6 weeks of age is included in straightaway ASA class 3. Now, what is ASA class 1? Let's have a comparison between ASA guidelines of 2014 and ASA classifications of 2020. Under class 1, both includes fit and healthy individuals, but ASA 2014 classifies non-obese patients under BMI 30 as ASA 1 category, which you will see in the next slide that in 2020, patients with BMI between 30 to 40 all are placed under ASA grade 2. Also, patients with no or minimal alcohol use in 2020 are classified under ASA grade 1 category, whereas in 2014, they were non-smoking patients with good exercise tolerance under ASA 1 with no mention about alcohol use. Now, both the classifications in ASA 2 category places the patients with mild systemic disease without any substantial functional limitations. In 2014, patients who were well-controlled hypertensives were under ASA 2, but 2020 guidelines have included not only well-controlled diabetics, but well-controlled hypertensive patients or patients with mild lung disease as ASA grade 2. Also, 2014 guidelines say that obesity with BMI under 35 falls under ASA grade 2 category. But 2020 guidelines say that obesity with BMI between 30 to 40 is straightaway class 2. Now, 2014 guidelines places frequent social drinker or cigarette smoker as ASA 2, and in 2020, current smoker and social alcohol drinker is placed under ASA 2. Now, in ASA grade 3 category, they both have included severe systemic disease with functional limitations in 2020, but in 2014, it says severe systemic disease that is non-life-threatening is ASA grade 3. And both says that functional limitation due to disease is ASA 3. Now, there are certain examples which have been included. Both say that poorly treated hypertension or diabetes is ASA 3, but 2020 has also included COPD as a ASA 3 category, whereas 2014's mentions about respiratory disease that only bronchospastic disease with intermittent exacerbations are ASA3. So if a patient has COPD, which is poorly controlled, it falls under ASA3 category. Now, regarding cardiovascular conditions, 2020 says that history of MI greater than 3 months or patients with CVA, transgenic ischemic attacks or CAD or stenting are under ASA3. But 2014 guidelines only mention about stable anginas who are placed under ASA grade 3 category. Also, 2020 says if patient has implanted pacemaker or moderately decreased ejection fraction, it is ASA grade 3, but 2014 mentions about only implanted pacemaker and no mention about ejection fraction was made in 2014 guidelines. Also, additional feature is in 2020 is about active hepatitis or a patient who has totally alcohol dependence or abuse is ASA3. In 2014, there was a mention about chronic renal failure, placing them under ASA3. But 2020 guidelines have also included that patients with end-stage renal disease who undergo regular dialysis are ASA3. So regular dialysis feature has been added in 2020 guidelines. So in ASA grade 3, COPD has been added in 2020. BMI greater than 40 has been added. In CVS, they have added history of CVA, TIA or CAD or stenting and moderate decreased ejection fraction as ASA3. Also, regular dialysis has been added. In both the years, both the categories, ASA4 is patient with systemic disease that is constant threat to life. But now certain examples have further been added, like in 2020, recent MI less than 3 months and along also CVA, TIA or CAD or stenting are ASA4, whereas 2014 only mentions about unstable angina or recent MI less than 3 months. No mention was made about CVA attacks or transgenic ischemic attacks or CAD or stenting. Also, symptomatic CHF has been included under ASA4 in 2014, but 2020 guidelines say that if there is severe reduction of ejection fraction, it is class 4. Now, 2014 says that poorly controlled uncontrolled COPD is ASA4, whereas in 2020 guidelines, as you saw in the previous slides, COPD was placed under ASA3. Now, it also mentions in 2020 that end-stage renal disease patients who are not undergoing regular scheduled dialysis are ASA4, whereas in 2014 guidelines, they have mentioned about only CRF in ASA3 category and there was no mention about dialysis at all. So it helps in further classifying the patients even with chronic renal failure. Now, ASA5 is in both the categories are moribund patients who are not expected to survive without the operation. In both the categories, examples of ASA5 included ruptured abdominal or thoracic aortic aneurysms or massive trauma with intracranial bleed with mass effects. But 2020 guidelines have further added that ischemic bowel with significant cardiac pathology or multiple organ or system dysfunction is ASA5. ASA6 in both the categories are brain dead patients where organs are being removed and there is intention of transplanting them into another patient. Both the categories have undertaken or emergency surgeries which were excluded in earlier guidelines have again now been included both in 2014 and 2020 as emergency grading E to the any category where there is emergency E is added, which says that if there is delay in treatment of the patient, it would lead to significant increase in threat to life or body part, which explains that urgency of the surgery is also a factor in the categorization of the patient undergoing surgery. Now, as I have already told, 2020 guidelines also includes pediatric patients. So a normal healthy child, if comes to you, who has normal BMI percentile for age, you will straight away place it under ASA1. Patient with mild systemic disease is ASA2. It includes asymptomatic congenital cardiac disease with well-controlled dysarrhythmias. Also, asthmatic children without any exacerbations or well-controlled epilepsy or non-insulin dependent diabetes mellitus, which is well-controlled, is ASA2. A child with normal BMI percentile for age was ASA1, and child with abnormal BMI percentile for age is ASA2. Similarly, a child with diabetes mellitus, or mild to moderate obstructive sleep apnea is ASA2. And you must remember, even if child has some kind of cancer, but it is in the state of remission, then it is ASA2. Even if child has ASA autism, if child has autism with mild limitation, it is ASA2. But a child with autism who is having significant features, it is not ASA2. Uncorrected stable congenital cardiac anomalies are ASA3. Child with asthma with exacerbations is ASA3. Poorly controlled epilepsy or poorly controlled insulin-dependent diabetes mellitus are ASA3. A morbid obese child is ASA3, or a malnourished child is also ASA3. A child with severe OSA is ASA3. Whenever there is difficult airway, suppose you get a syndromic child, then remember that it is straight away ASA3, no matter whether it is not having any further anomalies or not. But if difficult airway is there, then it is ASA3. Children on long-term parenteral nutrition are ASA3. And if an infant comes to you who has an age of less than 6 weeks of age, then you consider it as a ASA3 patient. So you have to be extra cautious. Also, pediatric patients with oncological state, renal failure, muscular dystrophy, cystic fibrosis, or history of organ transplantation are ASA3. So oncological state, which was in the remission phase, was grade 2. Now in the oncological state who is not remitting is grade 3. Symptomatic hydrocephalus or brain or any spinal cord malformation is ASA grade 3. And as we had discussed that infant with age less than 6 weeks was ASA2. Similarly, premature infant with post-conceptional age less than 60 weeks is ASA grade 3. Similarly, autism was grade 2, but autism with severe limitations or metabolic disease is grade 3. Pediatric patients with ASA grade 4 patients are the patients with severe systemic disease that is constant threat to life. So it includes symptomatic congenital cardiac disease, pediatric patients with congestive heart failure, patients with automatic implantable cardioverter defibrillators, patients having acute active sequelae of prematurity, having hypoxic ischemic encephalopathies, or patients in shock, sepsis, DIC, or on ventilatory support are ASA grade 4. Similarly, endocrinopathies in children are ASA grade 4, or severe trauma, severe respiratory distress, or advanced oncological state is ASA grade 4. What is ASA category 5 in pediatric patients? Patients with severe systemic disease that is constant threat to life is ASA grade 5. It includes examples of massive trauma with intracranial hemorrhage with massive mass effect, patient with respiratory failure or arrest, or malignant hypertension, decompensated congestive heart failure, or patients requiring ECMO are ASA 5. Also, like in adults, they have included ischemic bowel disease in the category 5, or hepatic encephalopathy or multiple organ system dysfunction as ASA grade 5. Pediatric patients in ASA grade 6 are the declared brain dead patients whose organs are being removed for organ donation. Coming on to obstetric patients. A normal pregnancy, though it is physiological, but has been included in ASA grade 2 patients because they are not considered as normal patient as a non-pregnant patient. When controlled gestational hypertension or a patient who has preeclampsia but there are no severe features can be taken as under category 2. Well-controlled diabetes is also, diet control, well-controlled diabetes is also ASA grade Preeclampsia with severe features. Remember, preeclampsia with no severe features, grade 2. Preeclampsia with severe features is grade 3. And you'll see further that preeclampsia with severe features, including HELLP syndrome, is ASA grade 4. Similarly, gestational diabetes with diet control was ASA 2, but gestational diabetes with complications or high insulin requirements is again ASA grade 3. Similarly, thrombophilic disease in pregnant patients who require anticoagulation is ASA 3. Preeclampsia with severe features complicated by HELLP or other adverse events is ASA grade 4. Peripartum cardiomyopathies with reduced ejection fraction of less than 40 is ASA grade 4. Uncorrected or decompensated heart disease, acquired or congenital, are ASA grade 4. In obstetric patients, ASA grade 5 failure is there, like in uterine rupture. But they have given one example, but you can correlate these examples with other clinical conditions and classify accordingly. ASA grade 6 is a declared brain dead patient whose organs are being removed for donor purposes. Like any other system, there are few limitations in ASA 2020 guidelines also. One of the very important factor which has been missed are geriatric patients. Like children, they also undergo physiological changes which are not pathological. Some changes are more rapid and intense, so it has a pathological relevance and it should be included in the further modification of ASA guidelines. Also, there is no mention about chronic pain examples which can be further considered. Thank you very much. Now I will discuss the scenarios. Coming on to a 45-year-old male who has a BMI of 36, hypertensive but controlled on medications, smoker, COPD since 10 years, and posted for lab poly. What do you think is the ASA classification? Let me show you further. A patient who is 35-year-old with well-controlled diabetes or hypertension, with obesity and BMI of 36, who is a current smoker, has COPD also, categorizes it under grade 4. Why? Because BMI of 36 falls under category 2. Hypertension controlled on medication is ASA 2. Smoking is under ASA 2, but COPD is under ASA 3. So this patient posted for lab poly is ASA 3 patient. Coming on to second scenario. You receive a pregnant female, 25-year-old, having preeclampsia with HELLP features, posted for cesarean section. So how will you categorize? Pregnancy is rated under grade 2. Preeclampsia with HELLP syndrome is preeclampsia is under grade 4. Pericardium myopathies are also under grade 4, and there is HELLP syndrome. So this patient falls under category of grade 4. Let's come on to scenario 3. A child comes to you who is 4 years old with Down syndrome and difficulty airway. There is VSD with CHF and there is hydrocephalus. So how do you place? Difficult airway is placed under ASA 3 category. So this child with also having his symptomatic hydrocephalus and having CHF has been placed under grade 4. So this is how you classify. If even two features are under AHA grade 3 and there is some feature which is under grade 4, you consider it as a grade 4. Thank you very much. I hope you enjoyed learning with me.
That was a wonderful presentation, Dr. Anshu. Thank you very much.
Thank you.